Yeah. Hi, this is Dr. Scott Hutchison, and today our Hutchison's Huddle is just me. And we're doing questions for questions that people put in, but we didn't get around to answering. So I'm going to spend some time kind of going through those. And then down the road here, we'll have another one with another fine guest. And shout outs to my prior cohorts in this effort to improve patient education through use of social media. Doctors Aaron Sperry, Dr. Alina Lackenpaul, Dr. Kevin Murphy, Dr. Celia Valenzuela. They all have been just fantastic, and I really appreciate their help, as do, I'm sure, a lot of patients. So anyway, a lot of questions on finer points on management of polycystic ovary syndrome. So if you know somebody with polycystic ovary syndrome or you have it, you can always refer back to this archived on our Facebook kind of deal. But let me get to some of the questions that people had in. So there were questions about managing facial hair in women with polycystic ovary syndrome. Facial hair, excess facial hair growth is a significant problem in some women with polycystic ovary syndrome, and it's obviously incredibly vexing. It's worth kind of talking about the physiology of recruitment of darker hair growth on the face. Those hairs are what we call terminal hairs, and which is sort of meaning the last step in how a hair goes from being a very, very fine vellus hair, kind of like what you see on a baby, to a big thick hair in like a really good beard, and or on your head, whatever. So those thicker, darker hairs, once they're actually thicker and darker, it's pretty difficult to go back. You can't really make them go back the other way. Of course, as we all get older, a lot of our body hair will fall out. Your hair on your head and your hair on your face get thinner. But for those of you who are blessed to be young and healthy, if you want to get rid of your facial hair, you have a few things that you can do. The main thing, I think, is if at the first sign that there may be any excess androgen production going on, like irregular periods in a teenager, get ahead of it. Don't just wait until, this teenage girl starts recruiting hair growth, around the edges of her lip or under her chin or whatever, or starts saying, hey, I've got a whole lot of body hair. Get that dealt with ahead of time. Not recruiting the hair is critical. So how do we not recruit hair? Get those androgen levels under control. So the teenager who has irregular periods needs to get evaluated. Most of them aren't wanting to get pregnant, so they probably should be on birth control pills if they don't have migraines with aura. And then nutrition, and we'll cover it tonight for people who have questions about nutrition in polycystic ovary syndrome. But trying to get ahead of the problem is really the most important thing. Now, if you're already there and you're like, wow, I got to shave every day, and a lot of our patients with polycystic ovary syndrome do, and it's hard not to feel self-conscious about that, but man, let me tell you, you're in good company. Once you're starting to get really lots of those terminal hairs in the face, probably the best thing to do, you got a couple of things. You can start destroying them, and one of the best ways is by plucking, because with repetitive plucking, you will destroy the dermal papilla that is generating that hair follicle with repetitive plucking. And this is why, you look at old bodybuilders, they take off their shirt, they hardly have any body hair because they've been waxed so many times. You can do waxing, plucking. I wouldn't do electrolysis, which is where you put a wire electrode into the hair follicle, because that can leave scarring. There's a medication that is, the trade name is Vanica, Vaniqa, and It's an eflornithine compound that inhibits an enzyme called ornithine decarboxylase. And that enzyme is really important for helping hair to grow. So if you put this stuff on the skin, then it can really keep those hairs from growing, keep them from being generated over time, or keep them from regrowing. So obviously, it's not a permanent solution. You have to keep taking it all the time. It's back on the market now. Apparently, there was a big shortage of it a while ago. So, but apparently it's back on. How much it's going to cost, God only knows. I just don't trust anybody in big pharma, and certainly for a medication that is the only one of its kind that's on patent, that they know that a lot of women would be desperate to get. I think that Vanica may be really, really expensive. I wouldn't be surprised if they're charging $100 a month for it or more. Other, stuff, laser hair removal works really well if you've got a pretty good contrast between the skin color and the hair. So if you're like really, really pale and you've got really dark hair, laser works really pretty well. It can work moderately well in other things. And I think that, if you have an interest, I would see a dermatologist. We have a few here in town who are very good at that. And I would look into that and see, what they would say. I think it's case by case as to far or how far that can go. Like waxing, plucking, laser, all these things, they're only going to hit the hair follicles that are going to be recruited that month. So you're not going to get them all that month. So you've got to go back for repeat treatments, because the way the hair physiology works is about a third of the hair follicles on your body are empty at any given time. About a third are growing actively, and about a third have a hair that's there. It's fully grown. Think of it as like a fully grown tree, but it's just not growing anymore. But it's not dying either. And that's why when you go in to get a haircut, when you go in to get like a bang cut, and certainly, my wife loves her bangs trimmed like constantly. So she'll say, "Oh, I need a bang trim." And you'll see slightly longer hairs than other ones. And the reason is, or sometimes significantly longer, because some of those hairs are growing and some of them aren't. So you have to keep in mind your expectations with like how many of these things you're going to destroy at any given time. And it may take several treatments and potentially months to really get a good result with laser. Now, if you never want the hair to come back, great, go ahead and laser it. Certainly if you're like a dude and you're thinking, hey, be kind of nice to wax because I wouldn't need to shave for a while, well, you're going to destroy a whole bunch of your hair follicles. But if you're like, man, I want to grow a beard now, it wouldn't be so good down the road. So I wouldn't wax or laser or anything for if there's any hope you might want to regrow that hair down the road. Along those lines, like I had a patient today who we were talking about, hey, did you ever use birth control pills before? Because we always want to know, like, if people have used pills, because they have so many non-contraceptive benefits. So birth control pills, decrease pelvic infection risk, probably decrease endometriosis. They certainly decrease the amount of bleeding people have. They decrease ovarian cancer risk. And so that's always a pertinent question, especially if they're heading into fertility therapy, where we may be using birth control pills for even suppression before in vitro. But I had said, hey, did you ever use birth control pills in the past? And she said, yeah, only for 2 months. And I said, why? And she said, well, my hair started falling out. And I couldn't get a good answer, from the provider about whether that was really a thing or not. So I stopped. And though, and we see the same thing, these hormonal treatments, whether it's a pill you're taking or it's a baby in your uterus that's starting to make a lot of hormone from the placenta, that's going to affect how the hair growth is as well. So typically during pregnancy, you'll get a whole bunch of extra estrogen, which will recruit all of those third of the hairs that are not growing at all. A lot of them are going to get kicked out by a new hair follicle or a new hair strand being pushed up from the dermal papilla. So it'll eject that old hair. And so you'll see all of this hair in the drain, but you're actually regrowing a bunch of hair underneath it. And some of the follicles that are empty and haven't been, growing anything at all, they're going to start to recruit hair too. So you'll hear women typically say, "Oh, I just the greatest hair when I was pregnant, and then after I delivered, it all fell out." But it'll all, not all of it falls out, but maybe it could be up to 2/3 of the hair falls out, and then you'll regrow a lot. You'll regrow it all back down the road, but it may not be as thick as that really high estrogen state. So anyway, so that's kind of a little bit about hair stuff. So let's talk about other stuff. So there's a question about polycystic ovary syndrome. What's the correlation between that and testosterone? Well, kind of the root of the problem with polycystic ovary syndrome for most people is a resistance to insulin. And that may be a little bit simplistic, but through a variety of maybe genetic factors and then maybe these imprinting factors, which if you want to go back and look at the conversation we had about polycystic ovary syndrome a while ago, you can flesh that out a little bit more, or you can look up epigenetic modification. But if your environment, or even the environment that your grandparents or parents were exposed to, puts you at risk for becoming more resistant to insulin, you basically need to make more insulin to control your blood sugar. And insulin has some pretty wide-reaching effects. So insulin is a hormone made by the pancreas that is great for lowering blood sugar, but it is also in the growth hormone class, and it does some weird stuff. And one of the things that it does is it tells the ovary to make testosterone. So when the ovary can make testosterone, just kind of like the testes can, not quite as much, but it can make a fair amount. And my feeling is it's sort of like the ovary saying, "Hey, look, I can do this, but do you really want me to do it? Because if I make testosterone, I'm not going to be able to ovulate for you either." Because high concentrations of testosterone within the ovary poison the way the follicles are being recruited. So that's how that extra testosterone poisons follicle growth. And it doesn't take very much extra testosterone that gets out into the bloodstream, and the concentrations are way higher in the ovary than they are in the bloodstream, but it doesn't take much of that extra testosterone kind of slipping out into circulation to start that whole recruitment process for hair growth. So, and some of that, is normal in puberty. So, people start getting body hair. It's typically axillary hair and pubic hair, in adolescence. But, and some, depending on ethnic background, some women may have more body hair than other women, and they ovulate beautifully, and they really don't. And it's really not a sign of any pathologic stuff, especially if it's just sort of on the extremities, like hairier legs or hairier arms. Certain ethnic groups that don't have a lot of body hair, like Native Americans, Asians, it's always a little bit concerning when those women start having a fair amount of hair on their chest or abdomen, because that they're probably way off the norm as far as testosterone production. And some of them actually may have tumors that are producing testosterone if you're seeing a whole lot of body hair. But anyway, that testosterone then is the thing that recruits the body hair, and then can make the hair on the crown start to get thinner. Certainly, you look at my hair now compared to 20 years ago, and it was a whole lot thicker, back in the day. So persistent testosterone exposure and conversion of testosterone to a more potent form of androgen called dihydrotestosterone in the skin can really do a number on the hair on your head. Anyway, so I hope that's helpful for people. If you have any other questions about that, I guess you can log in, you can ask me about them on there too. So then there were a lot of questions about if metformin is helpful before and during pregnancy, would it be something that you would continue to take after giving birth? And the short answer to that is yes. So, my feeling with it is if we get, if polycystic ovary syndrome is really kind of a derangement or perturbation of normal physiology, and then we fix it and you ovulate and you get pregnant, then maybe we should just stay on that whole path. So there's some downsides to metformin. I mean, metformin is cleared by the kidney. There's some risk of what's called lactic acidosis. Especially if people were to get like a car accident and they got IV contrast and they already had, a fair amount of renal dysfunction, there could be some downside there. But in the big picture, we know that a lot of women with polycystic ovary syndrome, probably about half, are going to transition into type 2 diabetes if we don't intervene. And then one of the most common medications for type 2 diabetics is metformin. So, my feeling with it is, okay, we can either sit there asleep at the switch and let the patient progress into type 2 diabetes, by which time they may already have some renal damage, blood vessel problems in their eyes or heart or wherever, and vessel plaques. Why are we doing that? I mean, let's just go ahead, let them, if what worked to get them pregnant and keep them in good shape and keep them out of getting gestational diabetes down the road why don't we just do that and keep that going? Along those lines, but it's metformin. I think the main benefit for metformin for most people is it just punishes you if you eat carbs. So when the carbs we're talking about are really sugars. Sugars are really probably the thing that, they get absorbed really fast. And metformin interferes with absorption of carbohydrate across the gut membrane. And so the downside for those of you who've been on metformin, you'll know this. I mean, if you sit there and you drink a glass of orange juice, you're not going to probably feel very good, and then you're going to get diarrhea a lot of the time. So the worst story I heard about was I had a friend who started it. Went over to a friend's house went with a friend of a friend to these people's house who she didn't really know. It was a Super Bowl party. They had all kinds of delicious carby food. So she ate it and drank it. And, later in the game, she was starting to feel a little rumbly. And then the game was ending. She started having diarrhea and she couldn't leave these people's house. She didn't really know because she was still having all this diarrhea and they were like wanting her out of there. So, I mean, it punishes you. For those of us who have to go to the operating room, I mean, you would think twice before you would drink some orange juice or have that granola bar that has a bunch of sugar in it. I mean, because you might have your colleagues ridicule you as you have diarrhea in your trough while you're operating. So anyway, so I think metformin that's its main benefit is really kind of keeping people on the straight and narrow with regard to nutrition. And I'm here with Karina, my coworker, and she's helping field some questions here too. So anyway, other stuff like inositol, if you've ovulated with inositol, a lot of our patients can't tolerate metformin. So if you have ovulated with inositol, which basically has no side effects, then I would definitely recommend that you kind of just continue that through your lifespan, because I downside to it. And it's hard to get the amount of inositol that people used to get, because people used to eat a lot more whole vegetables and a lot more whole legumes. So certainly inositol is I think a very good supplement to kind of keep going. With regard to keeping going, people, a lot of the time they view some of this stuff as like, it's only going to be temporary. And I think a lot of people are just like, I don't want to have to take medicine my whole life. So it's very common for us to see people with hypothyroidism, for example, who are on where we're like, whoa, you're pregnant now and you're not making enough thyroid hormone. We've got to give you more thyroid hormone to help the baby. A lot of those people, after they're done being pregnant, will stop. And then they'll show back up to one of us, down the road and say, hey man, I feel horrible, and we're like, whoa, we check your labs and your thyroid function is completely out of where it's supposed to be. We need to get you back on it. And they'll frequently say, well, hey, I just thought it was for when I was pregnant. So all of this stuff, I mean, I guess the best thing is just talk to your provider about, what the down the road plan is going to be to try to keep you healthy. There's a question, would removing the ovaries help reduce the side effects of PCOS? That's a super awesome question. And the short answer is yes, but you shouldn't do it, because the ovary, this is like, shooting the messenger. The ovaries and polycystic ovary syndrome are just being abused. They are just being abused. So yeah, they're making too much testosterone, but we got ways to keep that from happening. And down the road, when you finally are done having kids, and even when you're menopausal, those ovaries are going to make, they're going to make a little male hormone for you that gets converted to estrogen, but that's good. And that probably is helpful for bone and heart health. And there's some little sketchier data that it may reduce risk of colon cancer. So if you're not at high risk for ovarian cancer, I don't think I would tilt you towards that route. And and also the thing about taking out people's ovaries, especially if they're younger, like sub 45 or 40, man, it can be a rough transition. Most people go through menopause pretty easily, but there's a subset, and man, it's a lot of the people who have to have, total oophorectomy or removal of both ovaries earlier in life, who have horrible hot flushes, horrible vaginal dryness. Hot flush is so bad that they have just crushing insomnia. So, I don't think you want to go there with that. However, there's a lot, these genetic tests for cancers have gotten so good now over time that we now know that if you have a family history of like breast cancer, colon cancer, ovarian cancer, endometrial cancer, what's the other one? So colon, breast, ovarian, prostate, endometrial cancer. Those five, any of those five, you have a family history of somebody, aunt or uncle, who's under age 50 who got that, you probably should go ahead and get one of the panels. And you can talk to your doctor. There's different ones out there, and I don't want to like plug one or the other, but they're out there to see if you're at higher risk for some of these tumor markers. And it's like every year they add more of them. So you can have a pretty good sense of like if you're going to be at higher risk for ovarian cancer. And if that were the case, then certainly, it's probably a really good idea to go ahead and have your ovaries and fallopian tubes removed, when you're done, or done having kids, maybe into the early 40s or something like that. Along those lines, fallopian tubes are now thought to be responsible for about 40% of ovarian cancers. So even if you don't have a family history of ovarian cancer out there, I think it's important to, like, if somebody's going into your belly to like take out your appendix or take out your gallbladder or whatever, maybe ask them, hey, look, is it possible, could you get my GYN or somebody to come along and take out my fallopian tubes? A A lot of the general surgeons are not going to feel comfortable doing that, but maybe if you could coordinate that, that would be a really good idea. Certainly, if you have to have a laparoscopy with a GYN and you're done having kids, get your tubes out. I mean, there's just that operation is relatively very low pain. I mean, you have basically pain from the puncture sites, but it's not really that bad. So that would be very easy to do and might give you an edge for ovarian cancer prevention. I have a question. How important is a good diet when trying to conceive? How about alcohol intake? I hate to rain on your parade, but for the alcohol, you shouldn't drink it all. The data is not, we're never going to probably have a randomized controlled trial where they have one group drinking and the other group not drinking, where they put them into a study center where you totally control whether they, it's basically like a prison. That's how they do a lot of those phase 1 and 2, 3 drug trials, where they're really trying to make sure that people are doing, where they're controlling their situation well and they're not lying about what they're taking in as far as alcohol. So that's never going to happen. But in the European data, it's very clear that if you're drinking any alcohol at all, it takes you longer to get pregnant. On the American data, there was a group back east called Boston IVF. They looked retrospectively, so of course it's not a prospective randomized trial, but they looked at over 8,000 IVF cycles. And the reason they chose the IVF cycles, they have all this demographic information about these people, like how old are they? Did they have male factor? Did they have endometriosis? And when they teased out all that stuff, the drinkers, even 1 4-ounce glass of wine a week was associated with about a 20% less likelihood of getting pregnant with the IVF cycle. So I would strongly recommend that you don't drink for at least 2 months trying to get pregnant. And I would say that goes for guys too. So no alcohol whatsoever. With regard to nutrition, it really is, I think there's not any randomized data, but most of us who do this really feel like a Mediterranean diet that's really rich in fatty fish like salmon, sardines, don't wrinkle your nose, shellfish, nuts, eggs, organic vegetables, lots of leafy greens, lots of healthy fat like olive oil and even butter, and minimizing starchy fruits. I know the fruit grower is going to hate me, but hey, fruit is sugar, fruit is vegetable candy. Yeah, it's got antioxidants, but and I don't mind if people have like a handful of organic blueberries or raspberries, but eating a bunch of bananas, eating 5 or 6 pieces of fruit a day, you're not doing yourself any favor. That's just sugar. You're just ramping up insulin secretion. But that diet is probably the best overall. And there's really good data that if you look around the world for the people who live to be the oldest, the people who live to be 100, those people typically eat that way. And it's interesting. I mean, they may break week and they may, ice cream here and there, they may do whatever, but they don't eat a ton of it. They usually aren't eating sweets every day. They may drink alcohol, but they may not, but they're not usually eating a lot of junk food, processed food, and that kind of thing. So if it comes in a paper box or bag, if it has more than 3 or 4 ingredients, don't eat it. Honestly, everybody's always trying to make a buck in this country on food and everything else. And the snack food companies, they have a term called the bliss point for snack food. And it's that just perfect crunchiness, a little bit of sweet, salty, maybe a little spice in there, especially, in areas like here, like in Tucson, we all like spicy food, or most of us like spicy food around here. So they engineer it, they make it, in different, those of you who are from here, if you've been looking at the buses or the streetcars, you'll see one of our fine, spicy snack foods that's geared towards the Southwest market, displayed on the buses, but don't eat it. It's bad for you. There was a randomized study in the Netherlands a couple of years ago where they had guys eating those kind of snack foods, and then they had them, and another group not. And they then checked semen analysis periodically, and the snack food users had a progressive decline in their sperm quality and motility. So, I mean, for everybody, I'm begging you, don't eat that garbage. I mean, I don't have any self-control. If you put a bag of, Cheetos or Flamin' Hot Cheetos in front of me, I'll eat them all. But, I'm telling you, it's not good for you. What else here? As far as some of these other questions. And there's a question about, what if you're eating healthily, but you can't increase your dose of metformin to the 1,000 milligrams twice a day that we usually are shooting for? Don't beat yourself up about it. A lot of people can't tolerate higher doses. And what I've seen is that even 500 to 1,000 milligrams a day can be helpful. I think the best thing is to try to be just really mindful about, again, what you're eating. And, and if you're like me, you can't have other people bring in junk food into your house because, some people have better self-control than I do, but, my wife will go to bed before I do a lot of the time, and I will go through the house like a crack addict looking in drawers for like, oh, I know there used to be something in here, these cookies or Doritos or something like that, and I'll find it, and then I'll kill the whole thing. I'll just eat the whole thing. Same with ice cream and things like that. So less metformin, but way less refined carbohydrate going down your gullet is going to lead to better ovulatory function and better health for you down the road in the big picture. And again, keeping it up throughout life is really important. And it was interesting because so my spouse is an obstetrician, and she's just fantastic. And we share some patients, and one of our patients was in a while ago and had said to her, she had polycystic ovary syndrome. She'd gotten pregnant and done fine, but then had kind of veered off of that diet. And part of it was because she felt like eating that way brought back the stress of her infertility. And that had been this incredibly noxious, hurtful time for her. And so trying to go on that low refined carbohydrate diet for her and giving up a lot of those kind of comfort foods just was horrible, and kind of was interfering with her being a mother. So in her case, she actually, she's a really bright person. So she went and she got a counselor because she said to herself, I really kind of need to get around this. And then the counselor, kind of got her to look at it from a different way, like, oh, I'm not going to think about this nutritional plan being hurtful. I'm going to think about it as being helpful for me and my family. And then she was doing it, and now she's back feeling better again, and controlling all those symptoms of polycystic ovary syndrome that had kind of gotten away from her after the pregnancies. So anyway, long story short, whatever plan that we put you on that helps you get pregnant, you should probably stay on for the rest of your life. Along those lines, exercise is really important for oxidative stress reduction in eggs. I would really encourage you to do that. A lot of our polycystic ovary syndrome patients are overweight, and I got to tell you, exercise is really usually not any benefit for losing weight. It's really all about nutrition. I think we all should exercise a few high intensity workouts a week. It doesn't have to be long and drawn out. It can be, I love that little 7-minute workout. You could do other things that are just make you breathe hard for about 7 to 10 minutes a few times a week. That probably is the most important thing for dementia prevention that there is, because apparently with humans, our memory neurons are really linked to our motor neurons in a roundabout way. And if you're not moving and stressing your body, then your brain may just go through and go, these neurons aren't really helpful. Let's prune them back, and they may be all your memories, of all the good stuff in your life. So definitely, a good balanced life is also some exercise as well. What else here? So, and then somebody asked about, what about going on low carb while I'm metformin? Of course. I mean, it's always stunning to me, and other GYNs in this community who know this stuff well, that like a lot of our family practice and internal medicine doctors will put polycystic ovary syndrome patients on metformin and just like say, here's your prescription, and not tell them anything about the nutrition that needs to go with it. I mean, I'm a big fan of altering that nutrition for, before they even get started, preferably, but certainly at the 500 milligram dose. And then we stepwise up, so you take it 500 milligrams for a week, and then you go to 1,000 milligrams for a week, then 1,500 if you can take that. So like 500 milligrams morning, noon, and night. And then finally 2,000 milligrams, 1,000 in the morning, 1,000 at night. The thing about it though is, honestly, I think that, most people have to, it's kind of like taking off the training wheels. You tell them don't eat carbs, but they don't think about it. They eat some carbs, and then, hopefully like on that lower dose of metformin, they'll be like, ooh, I feel a little queasy. Ooh, I feel like I'm going to have diarrhea. And then they're like, oh, maybe it's that yogurt I ate, or, maybe I really can't have that granola bar. Let me see what's in that granola bar. And oh my gosh, there's 15 grams of sugar in this thing. So I think that's really what happens there along the way. But yeah, definitely getting that refined carbohydrate out of the diet is really important. And along those lines, that refined carbohydrate, honest to God, we're going to look at these food companies in another 20 years, and we're going to think about them like they're the tobacco companies, like Philip Morris and RJ Reynolds. I mean, they're trying. I mean, they don't want to lose market share. So, I mean, they're coming out with these products that are nominally healthier, and some of them down the road may be a whole lot healthier. But, you see these soda companies trying to shift to these flavored beverages that may have a lot of artificial sugars, where those are just bad for your gut bacteria that help you become more insulin sensitive. I'll be really happy when Nabisco or Kellogg's comes out with a kimchi that just has naturally fermented vegetables and good healthy bacteria in it. But don't hold your breath, because they're gonna keep trying to sell things that are sweet and that are addictive and that they know they can make for cheap and sell for big. So anyway, there's that. So somebody had a question about polycystic ovary syndrome for non-reproductive health. Yeah, the things we worry most about are transitioning into type 2 diabetes. So I always tell polycystic ovary syndrome patients down the road, make sure that, when you go in to like get your annual, and and the deal is now you don't have to get your PAP except every 3 years, but you really need to you need to go back into the GYN for your annual, because you're supposed to have a pelvic exam. They need to do your blood pressure and that kind of stuff. And also, that's the time for you to say, hey, look, should we recheck my thyroid function? Should we rescreen me for type 2 diabetes? Especially if there's been, for those two things, if there's been any weight gain or any increased fatigue or increased thirst or, increased urination, that kind of stuff. So, so type 2 diabetes, big risk. Polycystic ovary syndrome, probably in the end, just because of its link with hyperinsulinemia and obesity, is probably going to be associated with higher risk of breast cancer as well. So I think, again, trying to control this from early in life is really important. Other stuff, endometrial cancer or uterine lining cancer, we really worry about in polycystic ovary syndrome patients. So if you're not making progesterone on your own through ovulation, you really want to be taking it in some form. So, and that can be in a birth control pill, it can be in some other kind of progestin, which is a synthetic progesterone, or some other kind of progesterone, natural progesterone, or just getting you to ovulate. But, clearly, if you have a 30-some-year-old woman and she's not interested in getting pregnant, but she's having irregular periods, we don't want to just make her ovulate if she's sexually active, because, with a dude, because she may get pregnant. So let's just, think about it if you, tailor the treatment to the patient. Then somebody had a question about Turner syndrome and fertility. So for those of you who don't know, so Turner syndrome is where you have all of the chromosomes that you need except a second X chromosome. So women have two X chromosomes, men have an X and a Y. If you're missing that second X chromosome, there are some genes. And so chromosomes are these big packages of genetic material, big packages of DNA. And embedded in that second X chromosome, and they're alike, they're the same, basically. You get one from your father, one from your mother if you're female. So if you don't get one or the other, I mean, the genes they carry are about the same, but having two of them allows you to protect and nurture your egg reserve better, because there are some genes that are important for that. So if you don't have two X chromosomes, a lot of the time, by the time you even get to puberty, you're out of eggs. So a lot of those Turner's adolescents are going to kind of have delayed puberty. A fair amount of them will go all the way through puberty into around age 17, 18, and then they'll stop having periods. But they will have had breast development and everything else be kind of normal. They tend to have shorter stature. They tend to have what's called a cystic hygroma, a birth defect that can occur on the neck. That over time, after a while in embryonic life, can kind of shrink down into this thing that looks like kind of what they call a web neck. So a little bit of an extra bit of tissue on the sides of the neck. They can have some other skeletal abnormalities, and then they can have some cardiac problems and some connective tissue issues. They also tend to be at higher risk for developing diabetes down the road and hypothyroidism, and high blood pressure. So typically, for women with Turner syndrome who want to go ahead and get pregnant, we just say, hey, look, we're going to, if you haven't really gone through puberty to get breast development, we're going to do that. We're going to get everything going. We're going to try to get you as much height as you can. And then down the road, until you want to have a baby, we can have you on something that's like pretty socially acceptable for your age range, which would be like birth control pills, to make sure you get enough estrogen and progestin to keep your bones and your uterine lining healthy. Then when you want to get pregnant, you let us know, and we'll basically do donor egg IVF, or you can do embryo adoption. So those are really easy those are easy fixes. Now the problem is those pregnancies can be a lot more complicated. So typically the high risk OBs are going to have consults with those people as they go. And certainly for those of us in my field, it's very important that those patients only have single embryo transfers, because a twin pregnancy puts you at much higher risk for high blood pressure in pregnancy. And there have been a number of reported fatalities of Turner syndrome women where they would actually have a ruptured aorta during the pregnancy. So we need to be really careful with those pregnancies. So I hope that's helpful on Turner syndrome. But yeah, that's they can certainly have kids, but just usually not with their own eggs. However, there are some weird cases. A friend of mine from fellowship, Dr. David Carnevale, he was telling me about a patient who had a kind of an atypical Turner's, and they caught it really early in adolescence, and he was able to go ahead, even though she was only, I want to say 13 or so, do an egg retrieval, and they were able to bank a whole bunch of her eggs for her. So she, she's really super fortunate that they were able to do that, because she will probably then be able to go on and have her own biologic kids, which is really neat. So somebody says, how old was the oldest person to get pregnant with their own eggs? To my knowledge, it was a 54-year-old woman, and to beat all, it was a triplet pregnancy, a fraternal triplet. And it was not with fertility therapy. She was a migrant farm worker who was working in Washington State. So, but she was probably really healthy, and was physically active, certainly, and probably eating right and not eating too much, and probably not drinking and all that kind of stuff. The average age of menopause is about 50. What we tend to say is that reproductive, reasonable expectation for reproductive years is about 44. Certainly, the weird thing is that as the egg reserve, as the egg pool decreases over time, what tends to happen more often than usual is that there'll be very few like eggs recruited in a given month, and some of the other follicles that are in the ovaries are also making a hormone that puts the brakes on follicle stimulating hormone production. So if you don't have a lot of follicles around, in a roundabout way, you'll start dumping more follicle stimulating hormone from the pituitary gland. And that is probably why then, if you've got a few follicles and maybe they've got good eggs, that you can ovulate multiple follicles without any fertility drug in 40s, maybe into the 50s age range. And certainly that 54-year-old woman did. I have seen up to 8 follicles in a perimenopausal woman who was not taking fertility drug, and an estradiol of about 1,000. So, I mean, it's crazy sometimes how many follicles can be recruited in that age range. So anyway, but typically we say age 44. In our practice, we've had up through age 45 get pregnant with their own eggs with various things. But usually those are multiple cycles. I think I'm thinking back to that patient that was on about the 12th cycle of fertility drug and insemination. The patients who are in the 42, 43 range, I mean, they're having to do multiple cycles of IVF to try to get even an embryo or two that's genetically normal. So, I think it's okay to go ahead and try. We've had patients do as many as 11 cycles, either here or there or wherever. And there's an enormous emotional and financial toll on that, I think. So I don't encourage people to slog away at it that long. But certainly we've had age 43, 44 take home their own babies with different kinds of fertility treatment and one at 45. So, but anyway, most of the time, I think in that age range, it's probably better to go on to donor egg IVF or embryo adoption. Complicating it is the whole People Magazine thing or Us Magazine thing, where they'll trot out these pictures of these celebrities and they'll say, "Oh, yeah, it's my baby. And I froze my eggs." One celebrity a while ago said, "I froze my eggs when I was 40," and she was like 55 when she was having the baby. Well, let me tell you, there wasn't egg vitrification back then. So, I mean, I think it's okay for these people to make whatever story they want to make up, but it's really misleading to other people because it really makes it seem like, oh, you can just go to the fertility doctor and they'll be able to do IVF or they'll be able to do whatever. And years ago I had a patient who got pregnant with donor egg IVF and then told another patient who was in her late 40s, "Oh, you just go to Dr. Hutchison. He just gave me Clomid and I got pregnant. So have him give you some Clomid and then you'll get pregnant," which was sort of a kind of a weird thing to do to build up her expectation like that. But anyway, sometimes people they want to be private about what they've done, and they really may not want to tell the world everything that's going on. But anyway. Let me scroll through some of these things. If anybody has any more questions, ask them now, because it seems like I think we're pretty much done. All right. Well, thank you. Thanks for paying attention. And feel free to get on to our Facebook page, and you can look at the other ones. Thanks.